Agent, CEO, and founder of Duke Spine Institute. It is now September 8th, 2020, and today we've already performed a very major surgery, a revision surgery in a patient who developed problems with their spine above their old fusion, which was done 10 years ago. And now this next patient we're going to be doing is the more state-of-the-art surgery to repair herniated discs that are causing back pain and leg symptoms. Now this patient has primarily back pain, a little bit of leg symptom on the right side, but he has 3 discs in his lower back, the L3-4, 4, 5, 5, 1, that are not normal. They've been injured at some point. They have a tear, but they really are, for the most part, they look good structurally. They're not collapsed, they're not huge herniations, they're small. So this patient really has a choice. They either live with their back pain because there's nothing else that will fix it besides a fusion or the laser surgery, the Duke laser disc repair that we're about to do. And he didn't want to have a major fusion, and I don't blame him, right? All right, so this is Dr. Duke. We're going to get started, okay? You feel my hand on your back? All right. The first thing I'm going to do is give you some numbing medicine. You'll feel a little poke and some burning. There's nothing burning on your back, I promise. It's just the medicine going in. It's a little uncomfortable. Okay? That's my hand kind of probing around. I'm feeling for the iliac crest. All right, I'm going to give you just a little poke and a little bit of burning. And that's perfectly normal for the surgery. Don't jump off the table, okay? I apologize. It's a little uncomfortable. Just bear with me. Any questions for me before we get started? Now, unlike the last surgery we did, if you watched the first one, our patient is awake. There's no tube down his throat. He's going to have twilight sedation, meaning he's going to be asleep, but not yet. And we do the sleepiness by giving medicine in the vein. Whereas the last surgery we did sleepiness by giving the patient some gas that they breathe in. It's called an inhalational anesthetic. This patient, on the other hand, is going to be put to sleep through an intravenous drip. All right. Now, if you feel pain, I just want you to say, ouch. Don't move your body and try to move around, okay? Are you comfortable otherwise? All right, so just lay still, try to relax. If you're having pain, say, ouch, and we'll do our best to make you more comfortable. Doctor, if you can help me with that blood pressure. Is that uncomfortable for you, or? All right, let's see if I can try to keep it comfortable. So let me get back to telling you a little bit more about this patient. I'm not going to disclose any of his personal information, but I will tell you that he had a choice to make, either live with the back pain or try to get it fixed. And fixing it, there's really only one option, surgery. The question is which kind of surgery. And the surgery has to be done on the disc, the spinal disc, because the pain is coming from the spinal discs. So you have to go and do something to the spinal disc to make it not painful. And what he decided to do, one of the options I gave him was the laser surgery on those painful discs, and he has 3 of them. All right, shot. So we're going to use X-ray to navigate down to the disc, L3-4, L4-5, L5-S1. Hold on, Jordan. Let me put some more numbing medicine. Yeah, no, he's right. Oh, okay. It's for the skin. Sorry. Are you comfortable? Yeah. All right. It's always that first shot that's always the worst. I apologize. Whatever you can do, Doc, let's keep that blood pressure controlled. Good. All right, you're doing great. I'll let you know how things are going. In the meantime, I'm going to be trying to teach our audience a little bit, okay? All right. Shot. Let's go lateral. Let's see where we really are. Hazel, welcome to the operating room, where all the magic happens. All right, so the floor needs to go down or the table needs to come up. And you need to go further north with the fluoro because you're looking at his hips. Just a little bit. Shot, let's see where we are. All right, I guess you were probably better where you were. I apologize. So come south a little bit and let's wag and let's find 5-1. I want to start at 5-1. Damn allergies. All right, for those of you watching, what you're watching is a revolutionary new surgery that is not really going to be available where you live unless you live in Florida, so you're going to have to travel to get it. But is it worth traveling for? Absolutely. Okay, we need to wag the bottom. And the reason it's worth traveling for is because we're going to repair these 3 discs and get rid of the pain without actually doing open back surgery. We're going to make a small incision, so sure, there's still an incision and it's still real surgery, but we're not going to be cutting the patient open like you saw in the last surgery with a big incision. This is a tiny Band-Aid incision. Everything is done arthroscopically. All right, you do see the problem, right? So hopefully you're working on it. Keep going. So the problem is we're not lined up properly with the fluoro, but Jordan is working on that. Jordan, keep going until you get it right. You're almost there. You need to line up the L5-S1 a little bit better. Now, as I told you before, everyone that has a disc injury and is symptomatic with a disc injury, they all have different looking discs. The discs don't have a one characteristic appearance. But there is one thing that is universally true about all painful disc herniations, and that is that it's a posterior tear in the annulus. Posterior means it's a tear in the back of the disc. There's anterior, which is the front. Posterior is the back. Jordan, please. I'm begging you. Get there. You've taken far too many shots. You should be closer than you are. That's better. That's better. That's almost perfect. I would say you need to do a little orbiting. I see a double shadow on the superior facet. If you could just fix that. Shot. I think that's, I can't tell if that's worse or not. I want to say it's worse, but I'm not sure it's worse. Yeah, you tried the other way. I think, let's see that. I think it is worse. That's better, for sure. All right, that's better. So we got our pedicles pretty much superimposed almost, our superior facets almost. I think that's good. Let's just lock it there for now. We're not perfect, but we're pretty damn close. Everything's going good. Just relax. Now, what I like to try to do for people is I like to try to fix all 3 discs with 1 incision. And I don't mean 3 every time. Whatever the patient needs, right? So this patient needs 3. And I like to try to do it with 1 incision. You comfortable? You're doing fine. Everything's going well. Remember, if you feel pain, you're going to tell me, okay? Try not to move. Everything's going great, though. We're going to put you to sleep soon, but I need you awake just to help me in the beginning. Sean? All right, so I want to see if I can fix that right there. You see the double shadow on the sacrum or on the iliac? So I don't know if you need to adjust this, or I know we need to do something with the wag, probably about a degree on the wag. Show me. Move it and take a picture. Yeah, that's better, but now we need to move the whole fluoro south. Come on, Jordan. All right. Do you want me to tell you what to do, or can you see it? Shot. All right, that's actually, that may be the best we've had it so far. Yeah, let's leave it there. All right, as long as he doesn't move, I think we're good. Shot. Shot. Are you still comfortable? Shot. Shot. Let me know if you feel any discomfort. Shot. All right, AP. So we're right there in the foramen, getting close to the back of the disc, the herniation. And I'm pretty happy so far. I just want to verify everything on another view with the x-ray. You can never rely just on one view of the x-ray. You need to always double check. Yeah, I think we're pretty good there. Do you feel anything in your back? Uh-huh. It's important when you're taking x-ray pictures that you line the x-ray up properly. Shot. Shot. So that's the L5S1. And blood pressure, I don't know if you can get it down a little more for me. I would certainly like it a little lower, about 10 points, 15 points lower. Are you comfortable? All right, well, I intend to keep you that way. But you're doing fantastic, by the way. Everything is going as planned. So once we get our first positioning needle in position, I like to then make my incision. This is a 7mm incision, by the way, folks. This is tiny, absolutely tiny. And the reason I can do the entire surgery through this little incision is because we're going to do it endoscopically. Hazel, how you doing? Your legs ready to buckle yet? No. All right. So we're going to fix 3 discs with this little fingernail, half a dime width incision. Incredible. And it's all possible because of endoscopic technology. Sean? We all know about endoscopic surgery because we've heard of endoscopic surgery being done for orthopedic surgery, right? Endoscopic or arthroscopic shoulder surgery. Shot. There's arthroscopic knee surgery. Shot. Where'd you feel that? In the back, Shot? I apologize. Shot. Shot. And arthroscopic surgery, Shot, is not new. Arthroscopic surgery for the spine is. It's relatively new. Shot. 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 Are you okay? Huh? Yeah, well, that's right where your pain's coming from. So we're gonna put you to sleep soon, but I've got to check a few more things, and I just need about 5 more minutes of your time. And then we got to put your brain to sleep. And when you wake up, we'll be done. Yeah, we will. Don't worry. We're going to. That's what we're here for. We're here to make that pain go away forever. Shot. And we're gonna do it. I feel very confident. Shot. I had my Wheaties this morning. Shot. You're probably old enough to remember the old Wheaties commercials, right? You know, they used to have the Olympic athletes on there on those boxes of Wheaties. Shot? Shot? Is that possible that this is the worst shot? That felt like the worst herniation of all three. The top one. Okay, are you comfortable? Alright, so no more pain? Good. Still nothing? Huh? You do feel it? Is that your typical pain? Is that where you get pain normally? Is that part of your back? How high does it go on a scale of 1 to 10? What's the highest it went? A 9? Wow. You're very mellow for a 9. All right, that's fine. Everyone responds to pain differently. That's pretty cotton ballish, but is that better? You don't feel it? It's better now, though? All right. Huh? How bad is that on a scale of 1 to 10? 10, so 4, 5 is a 10, 5, 1 is a 9. Is that where you typically get back pain? Yeah. All right. So what's really interesting, everybody's a little different, but the pathophysiology of the disease is the same. And you have really small tears, but they're painful, very painful. And when we wake up, you'll be done. You won't have them anymore. Almost 5-1 is, if you're probably old enough, you've been around, Dr. Arcos, something called internal disc disruption you've probably heard of. I bet you 5 is an IDD. How bad is that? Is that where you typically get back pain? All right, so 3, 4 is a 10, 4, 5 is a 10, and 5, 1 is a 10. All right, you get to go to sleep. When you wake up, we'll be done. Okay. Well, folks, the entire surgery will be done through this tiny little cut. And we'll be fixing 3 discs. And just to give you an idea, I want you to count from 1 to 100 out loud. Okay, can you do that for me? Count out loud, 1 to 100. Huh? You got to count out loud so I can hear you. Shot. Shot, yeah. Keep going, you're doing fantastic. So folks, the whole surgery is done through this little cut. And look, the patient has blue blood. Not really. That's a dye that we use to stain the herniation so I can find the tear and repair the tear. This surgery you're about to watch is a surgery we developed here at Duke Spine Institute. It's done nowhere else in the world. And it's called the Duke Laser Disc Repair. It's a type of endoscopic surgery, and there's parts of the surgery that are done in other places, like the endoscopic part, the discogram. You know, we're not the first people to do a discogram. We're not the first people to do endoscopic surgery, but we are the first in the world to do what's called an annular debridement. Basically, the focus of this whole surgery is on the annulus, the torn annulus and the annular tear. It's a tear in the back of the disc, and that's where the back pain comes from, and that's where neck pain comes from. If you have thoracic pain, that's where thoracic pain comes from, if your pain's coming from a disc. So most back pain doesn't come from a herniated disc. It comes from other things like the facet joints. But when you do have discogenic back pain, it's coming from the tear in the back of the disc. And we're going to find that tear and fix it. You're doing great. Keep counting. So we're bringing our dilator down and we're about to enter the foramen. I want to make sure he's comfortable enough because this is the more stimulating part of the surgery. Let me know when I can proceed, Dr. Arcos. So we're right there coming up to the herniation. You see how that dark dye, it's kind of a grayish color. I injected in the middle of the disc where the tip of the needle is and it leaked out through the back. Well, that's a herniation. Look how big that herniation is. It's huge. That's the main target, is that herniation and the tear that it came out of. It's in the back of the disc. Shot? All right. No, we're just about there. And the patient is nice and comfortable and asleep. Okay, you're pulsing, right, Jordan? Thank you. So in we go. We're starting at L3-4. Shot? Take that. Shot. Perfect. No, that is not the right. There we go. We're going to, for those of you who have never seen endoscopic spine surgery, we're doing the whole surgery through a little tube. It looks like I brought my shake straw with me from McDonald's, but this is actually a tubular retractor. Shot. And a tubular retractor is just something that holds the tissues back so I can get down to the disc and fix it. All right, he's moving a little bit. He's not as comfortable as I'd like him to be, but if you're okay with him, I'm okay with him. He's not moving that much. Shot. So when we do this type of anesthesia with the patient asleep, it's kind of a, we're right on the cusp. We don't want to put the patient too asleep, and we don't want to keep him too awake. Shot. Too asleep, they stop breathing. Too awake, they remember everything and they hate you. Or at least they hate the anesthesiologist by the time I get done telling them who's responsible. Right, Hazel? Well, there's the tube. It's inside the L3-4 disc. Everyone agrees that's 3-4. Lay still, you're fine. Yeah, you're doing good, Dan. Everything's okay. Just lay still. People get uncomfortable because actually we're in the part of the disc where the pain's coming from. And that's the beauty of this approach, is we go from the skin right into the tear where the pain comes from. And we leave all the bones in the spine alone. Now, did you all watch that last surgery I did earlier today? Remember all that bone I had to remove? Laminectomy, and remember all that dissection I did in the beginning, that exposure? We don't have to do any of that for this surgery. That's the beauty of this surgery. We've already done the exposure. It's finished. That exposure took us hours. Hey, don't move. Let's put another quarter in the anesthesia machine. I know, I'm just joking.
We have a question.
I have to give Dr. Arcos a joke around a little bit. This is a shattered disc, by the way. Look at all the fragments in there, all collagenized. Yes, Sean. So even though the disc looks pretty good on MRI and X-ray, it's actually disrupted internally. And I was betting that he would have this condition called internal disc disruption. Just see all the little fragments. All right, that's the tear right there. That's what we're after. Dan, you're doing great. Lay still.
We have a question.
Go ahead.
One reviewer says, I've had a neck operation C4-5 and C7-T1. The fusions are holding, but the areas above and below are beginning to deteriorate. Do I need a whole new neck operation caged all the way up and down, or can it just be cleaned out?
So we have a viewer who's had I believe an anterior. They went through the front of the neck. They didn't specify that, but I'm gonna take a venture and say that's what they did, just because that's the more common type of surgery than going through the back. The doctor went through the front of their neck and fused the number, what was it, 5, 6, and C7-T1?
Yes, C4-5 and C7-T1.
Sorry, C4-5 and C6-7, I believe. But the point is there's a disc in between they didn't treat. And that disc is now causing problems for this person, and they want to know, do I need to have another fusion done, or can you go in there and repair it with a laser? I think that's what they're asking. The answer is yes, I can go in there just like this in your neck, and I can repair that disc with the laser. Then you don't have to have a fusion. All right, you can see the tear right there. You see it? The blue is the disc, the white is the tear. So one side and then the other side, and there's a tear right between. And this blue stuff is what's keeping the tear from healing. That blue stuff is the herniation. This is what Duke Spine Institute figured out. I figured it out 15 years ago. And then we published this data 8 years ago in Surgical Neurology International. So if you want to go back and look in PubMed, you'll find our original publication on the Duke laser disc repair. It's the first surgery in the world to describe repairing the annular tear. Someday, probably not too far from now, other surgeons will learn what I've been trying to teach them for 10 years now, that you don't have to do fusions anymore. We don't have to do artificial discs anymore. The future of spine surgery is right here. It's this procedure that I invented. And I want people to understand they don't have to go through fusions anymore. So to the person who asked, hey, I've had a fusion at 2 discs, can I have something like this done instead of another fusion? The answer is yes, you can. But right now, the only place you're going to find this surgery is in Florida at Duke Spine Institute. And we take patients from all over the world. We don't deny anybody. So, how much of this patient's back pain will we get rid of with the surgery? Our average is about 98% now. When I originally published our article, the first one, we were at about 85% elimination of axial pain. But over the years, the technique has gotten stronger and better. Our focus has been the annular tear rather than the herniation. And as a result of that, we've had better results with higher elimination of pain. Also, I've gotten more comfortable doing multi-levels. So, for example, in this patient right here, how many discs do we check? 3. How many discs did I think were painful based on his MRI? 3. So we tested those 3 discs, and all 3 of them are causing his pain. The worst, of course, is the top 2, the 3-4 and 4-5. L3-4, L4-5 herniations are the worst. They cause 10 out of 10 pain when I tested the disc. The bottom one caused, I think it was 9 out of 10. Is that what it was? Yeah, 9 out of 10 pain. So not all disc herniations create equal pain. Some are more painful than others, and that's why we test them. The test is called a discogram. How's he doing? Good. I'm perfectly fine where he's at. If you want to let him wake up a little bit, it's fine with me. Now, a lot of this stuff is scar tissue from inflammation. This is not a normal disc. Normal discs don't have this consistency here. This is just like, how do you explain it? I mean, the words I want to use to describe it are not terms that most people understand. Congealed, I think, is probably something good. Congealed. Basically, it's like wadded together, like glued together, melted together almost. And the melting comes from chronic inflammation. Like, look at that piece right there, that white thing. I'm going to try to grab it out. Cam, you're a superstar. Boy. So Cam is one of our medical assistants. He came on board with us a few months ago. Cam is going to go to medical school, and he's going to become an orthopedic surgeon. And right now he's learning the ropes. But, if you want to go to medical school in your lifetime, you really need to have some hands-on practical experience, either in a hospital or at places like Duke Spine Institute. We are strong supporters of education. That's why we're doing the broadcast. We believe in education and improving the quality of healthcare around the world, not just the United States, everywhere. Healthcare safety, healthcare outcomes. It's funny, I read an article over the weekend, I think it was on Becker's, but the author was talking about how important patient-reported outcomes are. And I'm thinking to myself, God, that's something that we've known about here at Duke Spine for the last 20 years. Other people are just starting to figure it out. What is a patient-reported outcome? It's basically what the patient thinks about the outcome of their surgery or their treatment. And if you're treating a patient for pain, the patient-reported outcome is the most important outcome. There's a piece of herniation. Stand by, laser. Yeah, Luis is right. Luis is another person who has been hugely instrumental in Duke Spine Institute's success over the years. Luis runs our operating rooms and sterile processing department. He has a medical background himself, completing medical school. All right, take that. So you can see we're debriding, which one is it? We're debriding the annular tear. Nice job, Cam. Learning from the best I can see.
You have another question.
Yeah.
One of our viewers says, I have 3 discs in my neck that are completely degenerated. It hurts really bad. Is it too late for me or no?
So one of our viewers says, I've got 3 disc herniations in my neck that have degenerated now really bad. Is it too late for me to have this surgery? The answer is not too late. Believe it or not, if you have pain, you can have this surgery. It doesn't matter how collapsed your disc is. It's not the collapsed disc that's the problem. It's this little bit of inflammatory tissue that I'm removing with the laser. That's your problem. And even the most collapsed discs can have it. It doesn't mean every collapsed disc has that inflammatory tissue, but the ones that are painful do have it. That's how they're painful. And that's really what we understand now that we didn't understand. Honestly, not even 10 years ago, nobody understood that. And people still don't understand it, unfortunately, which is why we try to teach the world a little bit more about it. Why is it important? Because you don't need to fuse those discs to get rid of the pain. That's the real message. You don't need to live with the pain, and you don't need to have major invasive surgery and put spacers and cages and fusion or artificial discs to get rid of the pain. We can do it with this laser, as long as you know what you're doing. And really, I've been telling you all what we do, and that is an annular debridement. It's really not that hard. So yes, we can fix your neck with the Duke laser disc repair. We do cervical surgeries all the time. It's very safe. We've had 0 complications in 16 years of doing the surgery, folks. 0. I'm not just talking about surgical complications. We've never had an anesthesia complication either. That's how safe this surgery is. Now, I'm not saying it's an easy surgery. Probably the hardest job is that of the anesthesiologist, which is to keep the patient asleep, but not make them too asleep they stop breathing. Anytime you do propofol, that's the hardest thing. So these patients are prone, and they're getting propofol. So it's not like these surgeries have 0 risk. They do have risk. They have all the risks of normal surgery and even more because the patient's airway is not secured with a tube. So these are still risky surgery, but in 16 years and over 1,100 of these surgeries, we've had no complications. Not a single patient has died or been paralyzed or nerve damage or anything, spinal fluid leak. That's an incredible record for spine surgery. What that tells you is it's very safe, very, very, very safe. You can come in and have your surgery done and not worry about, dying in the hospital like you would have to worry about with other types of spine surgery elsewhere. You know that you can go back to work in a day or 2 with restrictions, of course, minor restrictions, but related to lifting and bending and twisting. But eventually you go back to normal life. All right, we're just about done. There's the end of the tear right there. And then the epidural space, you can see a little bit of epidural fat. I can tell you right now this is very calcified and scarred up, collagenized from chronic inflammation. Now his tears are not big tears, they're small, but they're definitely there and they're definitely painful. He had 9 out of 10 pain. Now he's a pretty stoic patient because when he had 9 out of 10 pain, he said ouch, but he didn't jump off the table like some of our patients do. He just kind of arched his back a little bit, and I asked him, how much pain do you have? I thought he was going to say like 3 or 4, but he said 9 and 10, and I'm like, wow, okay. So either our anesthesiologist is doing a really good job of controlling his pain, or he's a very stoic patient. Stoic just means stoic like the Viking, you know, they don't really show their pain externally. But obviously he did have pain and he wanted it fixed, otherwise he wouldn't be laying on this operating table. This is all, look how chunky this is here. It's not, if this was a normal part of the disc, it would literally vaporize right away, just melt away like butter. But it's just so stuck together and tough. This is all abnormal tissue. This is not normal. That's the end plate right there. You see that? That's what an end plate looks like. It's pinkish. It's got some blood. But this is the back of the tear. This is where all the pain fibers are. This is where all the pain comes from. Again, discovered here at Duke Spine Institute. Just about done. This is lateral. I know it's hard to understand that part. Took me a few years to fully understand it. The three-dimensional anatomy. Neurosurgeons are pretty good with three-dimensional anatomy. That's one of the things we have to be good at to be a neurosurgeon, at least to be a good neurosurgeon. You got to be able to see the body three-dimensionally. I'm not talking about external features. I'm talking about things internally like organs and tissues. You got to understand the relationships. Three-dimensional relationship. What I mean by that, think about it. If you close your eyes, who's your neighbor? Can you picture their house? What color is it? What shape is the roof? You know, do they have grass in the front? Just like you can picture your neighbor's house next to your house and your other neighbor on the other side, and maybe you can even see the street to your neighborhood. That's the kind of three-dimensional memory a neurosurgeon has to have for the entire nervous system and the body, everything around the nervous system. And the reason for that is when you're operating on the nervous system, there's always a risk of like going too far in, going too far up, going too far down. You got to know what's there. You got to know if it's safe to go a little further. If you can't go any further, there's a blood vessel there you might damage or compromise and cause bleeding internally. So you've got to know where everything is. Otherwise you get into trouble real quick with the patient. The patient can die. All right, just about done. This is all part of that herniation. It's like concrete. This is an old herniation, an old injury. I think this patient has injured their disc years ago and probably just kept injuring it, and it never really healed properly because of this herniation here. Therefore, he's had pain. You have more questions?
None so far.
All right. Just about done. I'm going to show you guys the nerve root. Since we're at the L3-4 disc, it would be the L3 nerve root that you're going to see. Since we're on the right side of his back, you're going to see the right L3 nerve root. Okay? Laser off. The nerve root is going to be right up here. Oh, so it's surrounded by fat. Okay, so you're not going to be able to see it because it's covered in fat. I can't take the fat out, and there's no reason to. So, but the herniation was there. That's what we cleaned up. I'm going to suck the water out. Let me put this down, scope off. So that's the first one. Now I'm going to take the tube out. We've got one down, two more to go. Okay. We're going to take this tube out. I'm going to put a little pressure so any veins that are bleeding stop bleeding. Usually there's a little bit of bleeding that comes from the muscles. Remember, muscles have a lot of blood supply. You can come in with the fluoro, watch your arm, go south just a little bit here, yep. Muscles get a lot of blood supply. Anybody know why? Use. Yeah, they need oxygen. They need glucose. They need energy to work, right? And they need oxygen to basically create energy and use energy. So muscles are very vascular. That's why doctors give you shots in your muscle sometimes, because they know that that medicine they put in the muscle will be taken away and distributed throughout your body. It's called an intramuscular injection.
We have another question.
Yeah.
One of our viewers says, I'm having severe back pain and causes my legs to go stiff and swell up. Do you think it might be something to do with my disc?
So one of our viewers says they have back pain. It causes their leg to go stiff and swell up. The answer, and then they ask is, do you think that could be something to do with the disc? The answer is yes, I do. So here's why. Leg swelling and stiffness can come from a variety of things. One of the more notable causes is your veins. If you have a problem with the veins in your leg, like they're not circulating the blood back to your heart, it pools in your legs. Your legs can get stiff, they can get swollen, and they can become painful. But you never get back pain with that leg symptoms. So it would only be legs. Because you have back pain and your legs bothering you, it's more likely that it's a disc problem. We can answer the question for you definitively if you'll submit your MRI scan of your lower back on our website at dukespine.com. If you go to mri.dukespine.com, you can submit your MRI and I'll look at it personally and I'll let you know my opinion. And then we can do a phone conference on Skype for 15 minutes. It's all free. We don't charge for this for anybody around the world that wants it. And it's available free to the community, to the world, whoever wants answers. You know, that's what we're here for, to help people out. So my advice to you is submit your MRI and let me look at it and I'll tell you if it's a herniated disc. Okay. So there's no swelling, there's no bleeding, the muscle is nice and supple. We call it supple. Supple means soft, and it's kind of like if you push on a steak, which muscle of course is steak. Steak is muscle. If you push on a steak, shot, that's it right there. All right. If you push on a steak before you cook it, and you feel that how it kind of gives in to your fingertips when you press on it, that's what supple is, okay? Supple means it moves easily. There's no resistance, and that feels supple to me. So, you know, one thing you worry about is a hematoma or hematomata. Everyone says hematomata. That's true. It's a hematomata. It's basically heme is blood, tomato is a tomato. It's a swelling. So it's a swelling made from blood. You don't want a hematomata or hematoma in your muscle, which can happen. So after I take this thing out, I put a little pressure just to keep the muscle from doing that. All right, now we're going to L4-5. Shot. Got to keep the audience on their toes, you know, keep them excited, interested. That's it. We're going to be tap dancing at the end here. Did you bring your tap dance shoes, Hazel? Uh-huh. By the way, Hazel is the one who taught Arius how to drive a stick shift car. Take. Hazel did. She will forever be Arius Dukmajian. Probably going to be the most famous American driver in history. She taught him how to drive a stick shift. Okay? Not a paddle shifter, he already knew, but a stick shift. So he'll be famous someday, Hazel. Yeah, he's a quick learner. All right, we got a wiggling bottom here. Doctor? a wiggling bottom. Watch. If I push here, he starts to wiggle a little bit. All right. Are you awake? Let me know when I can start. So, with this kind of surgery, you want to make sure the patient goes to sleep right around the time that we start to pass the dilator or the tubular retractor through the annular tear. Remember, the annular tear is what's causing all their back pain. So we're going right through that painful area, which is perfect because we're not damaging the disc, we're actually going through the damaged disc that's already damaged, right in the spot that's causing his pain. So it's nice because as we pull the tube back, that painful area just falls right into our view and we use the laser to zap it away. All right, we're done with one disc. We're going to be done with the other one in a minute. You're doing great. Hope you're having sweet dreams. Let me know when. Can you all see that tip of the tubular tractor in the foramen right behind the disc there? It looks like an oval shape. Let me know when I can proceed. So I think the L5-S1 is going to be a minimal repair, I'm hoping, because it looks pretty cotton ballish. Shot. Just want to make sure I'm not advancing the tip of the dilator into the pelvis. Shot. It's so nice when patients are relaxed, because then I can advance it so easily without really having to use a lot of energy or force. Shot. That's perfect. All right. Sucky, sucky. Let's get that fluoro out of there. Luis is developing a sense of humor. It's good to have you here, Hazel. You'll be back where? Oh, nice. Well, yeah, we need to do something about that. Hazel, you're doing a fantastic job, just so you know. Okay? Don't believe anything you hear from anyone else. Any more questions, Sean, from our audience?
None currently.
All right, like once again, we're inside the disc. Maybe tempting to think that the red is just blood clot, but a lot of times it's not. It's actually inflammatory tissue. So we call that granulation tissue. That's the tear right there. So take that. Let me have the laser. Remember, this patient's height of the disc is very well preserved. As a matter of fact, I can tell you right now, I spoke to this patient ahead of time in clinic, and he had no hope because no one would fix his back. And the reason is that if you look at his MRI, it doesn't look bad at all. It looks pretty much normal, but it's not. If you look really carefully, you'll see there are 3 discs that are not normal. There's something different about them. They're darker. They're darker than the normal disc, and the other discs are definitely lighter. So it's just these 3 that are abnormal. Well, no one really took them serious, as unfortunately this is what happens to people with back pain in this country and probably other countries as well, is people just blew them off. There's nothing wrong with your back. It looks fine. Your MRI looks good. I don't see anything that could be causing that much pain. Just go do some exercises at home or go to the gym. Go see a psychiatrist. Go, cut your arm. Basically just get out of my office. There's nothing I can do to help you. And those doctors are right. There is nothing they can do to help the patient themselves. And that's what we need to change. We need to change the way people with back pain are thought about in medicine. Because right now they're just off, basically. Unless you have what's called the spondylolisthesis, where your bones are slipping on each other, no one in medicine takes you serious. The chiropractors just want to twist your back, and many of them believe that's all that you need, which of course it's not. It doesn't work to fix the problem. Doesn't mean chiropractors aren't valuable and important. Of course they are, but not for that, not for a herniated disc or a disc injury or discogenic pain, basically pain from a disc injury. Chiropractors can't fix pain from a disc injury. They can fix facet pain, pain from a facet joint that's arthritic. We're not treating that today. We're treating a painful disc, a painful herniated disc. When you have a herniated disc and you have pain from the herniated disc, a chiropractor cannot fix it. The only person that can fix it is a spine surgeon. But spine surgeons don't know how to fix it. Okay? They don't know how to fix it at all. My colleagues that are neurosurgeons don't believe back pain can be cured. They literally don't believe back pain can be cured. You understand what I'm saying? The only thing I can tell you, if you think of it as like an Olympic sprinter, all right? We used to believe that Olympic or world records couldn't be broken, that once they were set, that was it. No one's going to come along and break it. But of course, advances in technology with training, using weights, for example, in the gym, building muscle mass, building tone, developing new running techniques, timing. I mean, there's a whole science to it, but eventually we're able to break the world record again, and then again, and then again, and again. And what you're seeing is just every generation there's a new runner that can break the record. And it's not because they're just born fast, it's because they are developing themselves to break the record, to be better than the prior generation's runners. It's the same thing when it comes to back surgeons. There's the old guard who believes, what they were taught, what they remember from their experiences, that back pain cannot be cured. And then there's the newer generation of surgeons that, and I don't mean newer as in younger, because it could be a lot of the newer surgeons still don't believe back pain can be cured. Okay, you have to go with newer thinking generation, not chronologically newer, but those surgeons who understand pathophysiology of pain. They've taken the time to learn about it, because it's not really something taught during spine surgery or neurosurgery. Something you have to learn pretty much, unfortunately, as a niche area of expertise. Okay? And that's what I had to do. But we're going to change the way the world thinks about back pain. I kind of sat around for years waiting for someone else to do it, and it never happened. And then I realized, holy shit, no one's going to change the way they think about fixing back pain. I'm going to have to do it. I realized that was my calling, was to try to change the way the world thought about fixing back pain, curing back pain. And more importantly, the people who suffer with chronic back pain, I mean, it's horrible. I've really started to empathize with our patients. Really, truly, I got to be honest with you, when I started neurosurgery, I was not really empathetic, because neurosurgery is more about people with brain tumors and aneurysms, and I never really empathized with those people. But then when I started to see people in pain with spinal conditions, I really started to feel very badly for them, like the quality of their life was completely destroyed. And I studied something called epilepsy, which many of you know what epilepsy is. It's a condition of the brain where there are abnormal electrical discharges. And I realized just how debilitated, incapacitated people with epilepsy live their lives. They can't drive a car because it's against the law. They could have a seizure during the driving and they could kill themselves and someone else. They can't have a job, basically, because they could, during work, they could start having a seizure. They take these medications that attempt to stop or prevent seizures that don't work half the time. And these poor people have seizures after seizures after seizures. And it destroys their entire life. And I thought, my God, here's a medical condition that destroys people's lives, and I have the ability to fix it. And so, of course, I studied epilepsy for years, and I did research in epilepsy. I did NIH research in epilepsy at University of Florida with Dr. Roper. I did before that with Lou Cornacchia. And in the end, it wasn't really, epilepsy wasn't for me. It wasn't what I was meant to do. I was meant to address a bigger problem. I think a bigger problem. What I mean by bigger, I mean something that affects more people than epilepsy. Epilepsy affects a lot of people, but even bigger than epilepsy is back pain and neck pain. And the problem was my colleagues didn't take it seriously. They blew it off. They acted like people with chronic back pain didn't really have a medical problem. They acted like people with brain tumors were the only people who were suffering, or people with aneurysms were the only people who were suffering. And it's like, no, there's millions and millions, hundreds of millions of people with chronic back pain that are suffering. And everybody in their life is suffering because they have to deal with these people and their misery and their inability to live a normal life. So I guess you could say that I went for fixing a disease that has a huge footprint or impact on society, and that's chronic back pain. And I did it because I didn't see anyone else really doing it. I saw the pain management guys trying, but they couldn't fix a lot of the causes of back pain. Only a surgeon could, and surgeons weren't taking it serious at all. They were ignoring it. And so I realized I had to step in and do something. So that's kind of why I devoted my life to curing back and neck pain, is because there are types of back and neck pain that require a surgeon, and there aren't many surgeons that are interested and dedicated in doing it. Anyway, I'm talking because you guys aren't asking me questions. So as soon as you start asking me questions, I'll shut up. I'll answer your questions instead. Right, Cam? Right. You're supposed to say, yeah. You know what movie that's from? No. Yeah. Yeah. No, it's an old movie. It's a scene in jail. I'll give you guys a chance to think about it. Any questions from our audience?
We do have one.
What do you got?
So a viewer wants to know, can the inflammation return after the surgery is done?
So a viewer wants to know, can the inflammation in the back of the disc return after the surgery is done? The answer is no. The reason the inflammation is there is not because of the tear. It's because there's the blue stuff, the nucleus, squeezed into the tear. And that's what I'm removing with the laser. So as long as this patient doesn't re-squeeze blue stuff into their tear, they won't have the inflammation. Of course, they'll have the normal inflammation of healing, like everybody does after every surgery, but they won't have the prolonged inflammation that they've had for year after year after year. Right here, you see this right here? This stuff right there. That is the interposed nucleus pulposus. That's the cause of the inflammation right there. I'm going to make sure I get that stuff out. We're not going to be done till it's gone. So to answer your question, no, the inflammation will not come back unless the person re-injures their disc. Like they lift something heavy or they bend over and try to pick something up. Then they squeeze more of that jelly out into the tear before the tear is healed. So it's really important, if you have this kind of surgery, the Duke laser disc repair, you cannot do too much stuff until your disc is healed. And that, unfortunately, 1% of my patients end up re-injuring their disc, re-herniating it, because they think, oh, I'm doing so good, I feel great, I'm just going to go whatever, I'm going to go be the bionic man. And they go try to pick something heavy up or bend over at their waist, and bam, they push out another piece of jelly from the center of the disc out through the tear that hasn't healed yet. It's been debrided, but it hasn't healed. Okay? So the answer is no, not normally. But in 1% of my patients, they do re-injure their disc and squeeze out more jelly. That's why we put everybody in a back brace, and we put everybody with restrictions for usually about 3 months. It takes 1 year to fully heal that tear, so the inflammation won't ever come back. But the inflammation from the surgery is gone usually within a week, week and a half. Good question. Very good question. I love the questions from the audience. Keep the questions coming. Just about done here with this disc. Looking around. I think I'm going to get this area too. Doesn't look normal. How are we doing on irrigation over there? All right, just about done. This is the last of the herniation. A little bit of calcium there. See the gold color? Dystrophic calcium. That's what happens when the laser hits it. It turns it a gold color. Any questions? No?
We do not have any more.
All right. Okay, good. I think we're pretty much done here. I don't want to take out any more than I need to. And I think we've done what we need to do. Got one more to go. The bottom one. By the way, the tears aren't always right in the center of the annulus. Sometimes they go up or down. Like this one here is going up, close to the end plate, you know? Just ripped right off. So tears aren't always exactly in the same place. A little bit of fat. Let's see if we can find the nerve up there. Again, too much fat around the nerve, not going to see it. Let me just get some of this stuff right here. This is still a little bit of herniation. See that little blood vessel right there bleeding kind of in the foreground? It's pretty cool, huh? That's literally like not a capillary, but small little venule. See if we can get it to stop. Yeah, there it goes. We got it. So the laser is good at stopping bleeding too. Laser off. As long as you wield it properly. Just having a look. I don't see anything more. It's all looking good, We're done at that level. Got one more level to do, L5S1. I don't expect 5-1 to be too long of a level because it's got a tiny tear and it's a really well preserved disc, but sometimes I get surprised with internal disc disruption. What internal disc disruption is, it was a term used many years ago, back in the 70s I think, and there was surgeons that were smart that actually treated back pain and realized that not all painful discs had really abnormal morphology. Morphology means the shape of something. They looked at some of these patients' discs on x-ray and said, wow, or MRI, early MRI, they said, wow, the disc looks pretty damn normal on the MRI, but I believe the disc is the source of the pain. And they described a condition called internal disc disruption, IDD. And people kind of laughed about it, and everyone thought they were crazy. But the reality is, I've seen some patients like this one, I think is going to end up being, where the disc is pretty well preserved, very good height, very good fullness, thickness, water content. MRI looks almost normal, but it's painful because the inside of it is just blasted. Looks like a bomb blew up inside of a container or something. So let's get in there and find out. It's our last disc. This is the L5S1. Shot. All right, guide wires in. Whoop, shot. Good. A little sticky there. Bring our dilator down. Remember, this is the dilator. It looks like a little metal pencil. So far, we've lost about 7 mils of blood shot. A little more than usual. We normally lose about 5 or less, but this patient we've lost a little more. Blood pressure is really good. So it's not, 7 mils of blood is nothing. It's like, cutting your finger badly. That's it right there? All right. Shot? Yep. Mallet and thing. Shot. Any more questions from our audience? Is that it? Right there?
We have a question. If the disc collapses and there's no more jelly inside, how do you make it the correct size again?
Great question. If the disc collapses and there's no more jelly inside, how do you get it to the correct size again? The answer, you don't. You don't. The truth is, there are literally millions of people living with completely collapsed discs, bone on bone, that have no pain in their back, no pain in their neck, no pain in their leg or arm. They're perfectly normal. Now they've lost about 1 degree of movement, 1 degree, which is nothing. So the disc is gone, but they have no symptoms at all. And guess what we do for those people? Nothing. We don't do anything. There's no reason to do anything. You don't need to have a disc. This surgery is not about giving somebody a disc. This surgery is about getting rid of pain so people can have a normal life and do everything they want to do. There is no need to give somebody back their disc height. There is sometimes a need to give them back their disc height so you can correct their alignment so they have a shot. Look at that. I knew it. It is internal disc disruption. Look at it pushing this thing out. Shot. It's just pushing this dilator out. Oh well, it's out. Not much I can do about it. Let's go take a peeky. A lot of pressure in there. What I found is with this internal disc disruption, there's a lot of pressure on the inside. Why? Guess what inflammation does? It causes swelling. What does swelling do? It's like a compartment syndrome. Wait a second, Ann. Where are you going? How's our patient doing? He's under good control. Did he get his special medicine? Perfect. All right. It's amazing how good life can be when you nail it, when you get everything just right. That's our first patient getting ready to go home. Of course, I can't send them home until I'm done in here because I got to go check on him. Last time I checked on him, his pain was under control, and now he's up walking to the bathroom, ready to go home. So, all right. Did I answer the last question all the way? Am I just rambling on again? Yeah. There it is. Yep. Yeah. Remember, this disc won't have a lot of stuff, but I have a feeling that the jelly on the inside is going to be under pressure. So let's do this. Take it. As soon as I get through the annulus, I'll bet you the blue stuff starts coming. Can't do that. Cannot do that. That's what Luis is talking about. That's what makes your job hard, is making sure that doesn't happen. Okay? Holding a wire is easy, but holding it right is hard. This is the last of the 3 discs we're here to fix. You can see a little bit of annular material. This is a lot of scar tissue here. So, getting back to the question, it's not about having discs. Life is about having painless discs. Painless discs. Discs that don't cause pain. That's what our goal here is, getting rid of the pain. If you want a disc, we can give you a disc. Costs extra money, but you won't be any happier having a disc than you would be having laser surgery. But to build that disc back up, we can either put a what's called a peak spacer or a peak cage, or we can put a titanium cage, or we can put an artificial disc. We can put whatever you want us to put as long as it's FDA approved. We can stick it inside your disc. It won't make you happy, I guarantee it. What will make you happy is not having pain. And that's what we specialize in here at Duke Spine, not basically taking people's pain away. The discs will never look normal. Don't expect to have surgery on any level by anyone in 2020 or before. There's no way to make your disc look normal. There's one way. You don't want to know what it is. It's crazy. And I would never recommend it, and I would never do it. But I'll tell you about it since you're asking. You are asking, aren't you? You know, guys, there is an element of humor in what I'm saying. You could, laugh once in a while. So the way you get a normal looking disc when you don't have a normal looking disc is a process called transplantation. And it's being done. It's been done experimentally in other countries, not the United States. And it's basically where you take a dead person who just died and you go in and you hack out their disc with a chisel right through their belly, chop it out, and then you take a real normal human living being like the person with a collapsed disc, you open their spine up and you hack out their disc. And by the way, the only way to do that is through the front. And surgery through the belly, through the front, is extremely dangerous in its own right. Now you're adding dead people's discs into your spine and hoping they fuse in. That's the only way to get a normal looking disc today. But I'm telling you, you don't want that. You don't need it. It won't help you. It won't benefit you. And of course it's illegal. Unless you go to some crazy country. And I won't say any crazy country names, but you all know what I'm thinking. And over in that crazy country, you could probably get it done. The first people to do it are the Chinese. They published a paper on it about a year ago. I think they did it in a dog or a sheep or something. So it wasn't even done in a human. But I'm sure they'll be doing it in humans very soon. But I'm telling you, bad idea. Bad, bad, bad idea. All right, we're just about done. I'm just putting the final touches. I'll be done in 5 minutes, doctor. I'm going to take another couple of questions. If you've got them, it's time to ask them. So type them up. Let us know what's on your mind. I'll do my best to answer the questions. We have anything? Any biters?
Not at the moment.
Huh?
None at the moment.
Anybody figure out the movie? It's huh? Nope. My Cousin Vinny is not it. It's an oldie. It's a little bit older than My Cousin Vinny. It's a movie with Eddie Murphy. Anybody remember Eddie Murphy? It's called Trading Places. Trading Places. Have you ever seen it?
I believe so. It's the one that you play with a millionaire or something.
Yeah. Very funny movie. Anyway, here's a jail scene. Eddie Murphy. Good stuff. No. I got a little bit more right there. Just under the fat. Trading Places. If you haven't seen it, it's probably about, what, 30 years old now? 25, 30 years old? Great movie. Very, very good movie. And of course, Eddie Murphy's in it. So anytime you got Eddie Murphy, you know you're going to be laughing.
We have another question.
Dan Aykroyd as well. And what's her name? The female actress. Famous female actress. Anybody remember? Jamie Lee Curtis. That's it. Jamie Lee Curtis. Beautiful woman. All right. Anyway, sorry. Back to the question.
One of our viewers says, do you recommend out to surgeons near where people live?
I'm sorry. I really couldn't hear the question. Your voice kind of faded.
Basically, our viewer is asking, if you review an image, do you recommend to other surgeons near to where people live?
Honest to God, I heard when you review an image, do you recommend to other surgeons?
Closer to where people live.
Oh, well, I recommend a surgeon near where you live. Is that what the question is?
Yes.
I don't do that because A, I don't know the surgeons near where you live, and B, I can guarantee you they don't do surgery the way we do here at Duke Spine. So, unfortunately, there's a lot of mediocre surgeons in the world, and unfortunately, most likely, there's not going to be a good surgeon where you live. That's why we have people that fly from all over the world. But I'm not trying to sound arrogant, I promise you. I just want to be as honest with you as I can. And I can tell you right now, if you want endoscopic laser surgery of this type that fixes the back pain or neck pain, you need to come to Florida. There's nowhere else you're going to go to get it done. Okay? I'm sorry, it's just a God's honest truth. I had to go through a lot of extra training overseas to learn this basics of this technique. So I can tell you it's not taught in the United States. You're not going to find this type of surgery done. You'll find it some endoscopic surgery. For example, in Phoenix, Arizona, Dr. Anthony Young, I think he's retiring, but he does endoscopic surgery, but he doesn't do the Duke laser disc repair. So you're not going to find the Duke laser disc repair anywhere else. It's really a new, novel technique. All right, we're done here. I wonder if we'll see the nerve root. There it is. The white thing right there is the nerve root. So you can see how nice and well preserved it is. Again, we didn't have to take much of the 5-1 disc out. Well, you know, who makes the stealth bomber? Come on. I don't think it's Harris. Northrop Grumman or Lockheed Martin. I think it's Lockheed Martin. What you're asking me is like, I live in, I don't know, Wisconsin, because I was just there. Where can I find a stealth bomber store? It's like, I don't think you understand. We're the only one that make the stealth bomber, right? And we're located in wherever they're located. Area 51. My point is you can't just go anywhere and get this kind of surgery. That's the whole point of us broadcasting, is we want you to know that it even exists because your surgeon doesn't do it. You okay? Do you live locally? Huh? Oh, wow. We got a local boy here. We get a lot of people from all over the world. This one happens to be coming 30 minutes away. Not bad. All right, we're done, my friend. We're all done. You're going to be a happy camper. We found your 3 painful discs and we fixed all 3 without incident. If you're unhappy about anything at all, just blame it on the anesthesiologist, okay? All right, guys. Everyone, look, the whole surgery was done through this tiny little cut right there. You see that? 7 millimeters. Beautiful job, everyone. The muscles are nice and supple. There's no hematoma. And you, Hazel, star of the show. Thank you. Everybody, great job. Thank you.
So can you tell when one disc has more, like, what was that word you used?
Collagenized scar tissue.
Like when one's a lot more dense than the other?
Yeah. So the question was, can you tell, while you're in there, Dr. Duke, playing around with the laser, can you tell which discs have more scar tissue in them, which have more collagen? The answer is yes. The more dense the collagen, the more inflammation the patient's had in that disc over the years, the more scar tissue there will be. The more scar tissue there will be, the thicker and tougher it is to zap away with the laser. And the stuff that's been around a really long time gets calcified, so it turns golden color. That's the calcium reacting to the laser. It turns basically like a copper color. Copper? Yeah. Great questions. And if you guys have questions, write them up. I'll be over there to talk to you in just a minute. I'm going to finish up here in the operating room first. and maybe we'll see you again on Thursday.